Good morning, everyone, and welcome to the second UK Health Data Research Alliance Symposium, all of us together. I'm Caroline Cake, Chief Executive of HDR UK, and on behalf of Andrew Morris, Director of HDR UK, and all of my colleagues, a very warm welcome to everyone joining us today. We're absolutely delighted to see so many people who want to learn about and be part of UK health data research. So 2020 has been an extraordinary year for all of us. And I think this picture tells that story quite well. This is a photo from our first Alliance Symposium on the 4th of February in 2020. As you can see, there were about 100 of us there, and we have nearly 500 people signed up for the event today. So phenomenal growth in how the community has developed through the year. But also, I think there's quite an interesting kind of seeing how close we all are together, the lack of face masks, and what has become of all of those name tags. So health data science has played an extraordinary part in this extraordinary year. And there are three lessons I just wanted to kind of draw out, which as we start the conversation today, which I will draw on throughout the day. So the first one is that data is clearly shown to be a key resource to help save lives. And I think that's been demonstrated throughout COVID. The second one is then the getting the value from data and really being able to use it requires people with a really wide range of different skills working together, be that experts in information governance, or the health data researchers, or the data engineers, really requires all of us working together. And the third lesson is that the patients and public are real enablers and important advocates of this work, and so need to be integrated throughout. So today at the Alliance Symposium, we're going to be celebrating what's already been achieved by working together in health data science, and then how far we can go together. And what we're going to be doing is covering through these 4 points here is we're going to be starting off in this conversation this morning, some of the health data science lessons from COVID. And then we'll be talking about trustworthy access to health data for COVID and beyond. And then looking at scaling up, how we can actually scale up data science capabilities and impacts. And then looking towards federation and how we leverage the diversity and scale within the UK and internationally. We've had a wonderful advisory group supporting us on curating the sessions today, and I think you're going to have a really enjoyable day through a whole range of different topics. As you can see, for those of you on Twitter, there's the hashtags there, so it'd be fantastic if you can share your thoughts and comments on that. So now let's get started. We have a wonderful group of speakers and panelists throughout the day, and to open today, I'm absolutely delighted to welcome Ottoline Laser. Ottoline has been the Chief Executive at UK Research and Innovation since June, so an extraordinary time to be leading the organisation, and a very warm welcome to you, Ottoline. Over to you.
Thank you very much indeed for the warm welcome, and thank you for inviting me to this wonderful symposium. It's really a pleasure to be here, and I think the work that HDR UK and this alliance is doing is just crucial and really emblematic of a lot of the issues facing the research and innovation system at the moment. And I think there are two things I would really like to highlight that HDR UK is key to delivering in a really high quality research and innovation system that successfully links in a really embedded network research, discovery to public good. And those two things are data and collaboration. And whilst I think that's probably a very uncontroversial statement, I think it's really worth remembering that both of those things are just transformed compared to how they were, for example, when I started my research career. I'm still pretending that I'm quite young, and it wasn't that long ago that I started my research career. But for example, when I was starting, if you wanted to get a copy of somebody's research paper, and that's effectively what data sharing was in those days, you walked to the library, you took the physical journal off the shelf, you put it on the photocopier, and you pressed the button, and you got a rather scrappy copy. And if you wanted a better copy, you could request a reprint from them. So when you published your paper, you ordered a big stack of lovely shiny reprints from the journal with all the nice color pictures, and you put them in your office in a pile. And then people sent you these little cards saying, please can I have a reprint of your paper, blah, 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 with their address in the corner. And you cut it out and you put one of the reprints in the envelope and you stuck their address onto the envelope and you posted it to them. And that was data sharing at the start of my career. And that was really, honestly, not that long ago. So the extraordinary rate of change of how things work and how we can collaborate and the opportunities is kind of breathtaking. And so it's not really surprising that we are running very hard to keep up, and that that rate of change continues apace, both in terms of the way in which we can collect data, the way in which those data can be stored and curated, how those data can be linked and shared, and the extraordinary rate of development of the analytical tools that we can use to extract understanding and meaning from those data. And this in the week when DeepMind have announced extraordinary progress in solving protein structure based on the protein sequence data that we have such a lot of. So just amazing rate of change, amazing opportunities, and a huge challenge to make the most of those opportunities. And so I think for me, in addressing that challenge, there are three things I would like to say a tiny bit about each. And the first is the issues around data quality and curation. The second, the data connectivity. And the third, crucially, how we can ensure the equitable distribution of the costs and benefits of all of these processes in delivering that public good that's so important. And I think, as with so much in our society, concerns or issues or energy around all of those three areas has been really highlighted and amplified by the pandemic. And the pandemic has also provided an opportunity to reset the system in a better way as we move forward. And I think that HDR UK and this alliance is in a really fantastic position to contribute to those efforts. So just very quick word on each of those things. I think on data quality, we can see that particularly in a complex domain like health, there will always be compromises in the quality of health data. And the way and the many different ways, the many different types of data and the environments in which they're collected means we will never be able to get perfect data. Nonetheless, we have to work harder, I think, to ensure that the quality of the data we have and the extent to which it represents fully the communities, the relevant communities of interest is really important. And there are a whole range of issues to do with that kind of representational bias that I think are relevant, and they include not only how we collect and curate that data, who is involved in all of those processes, including the analysis, but also the key research challenge of devising analytical tools that can deal with patchy, incomplete, imperfect, biased data sets. And we mustn't forget that last point, because I think that's a really important tool in our box, given that it's important to be pragmatic about the extent to which one can collect the perfect data set and doesn't want some poor patient sitting there being interviewed for an hour by some healthcare practitioner about all the things that we would really ideally like to know in some standard ontology. So data quality, super important, and the representativeness of the data and the people and the tools that we use to analyze those data, key. Broader kind of connectivity issues and the kind of many infrastructures in terms of hardware, software, people that are required to drive high quality connectivity, really important. And I think the challenge we face there is that a lot of that work is in some ways invisible. And again, the needs move very, very quickly. And it's expensive. And all of those things make it quite a challenge for funders, particularly, to think carefully and properly about how to invest in the continual upgrading needed to all of those things. Next year, there will always be a better computer. So why do I buy one this year? So how you put in place a really high quality strategy that takes into account the continuous need to invest in these kind of invisible infrastructures, I think is a really difficult challenge. And anything your alliance can do to help us think about that would be much appreciated. And then lastly, just a couple of things about the key centrality of ensuring that this extraordinary revolution and the opportunities that come with it involve really careful thinking about the equitable distribution of the benefits and the potential costs or harms that go with it. This is a really tricky area, and in the health area particularly so, because of the huge sensitivities around health data in the context of privacy and confidentiality, but also in the context of the extraordinary benefits that the effective and responsible use of health data can bring. And I think, I've worked on quite a lot of data-related projects over the last decade or so, including with the Nuffield Council on Bioethics and the Royal Society and the British Academy. And those projects have made me very alert to the extraordinary sensitivities around health data. And I think it's key that we address those and engage with those sensitivities, but not in a knee-jerk way that results in a kind of hyper-cautious, hyper-insulatory response, which I have heard quite often over that last decade. And I like the Caldecott review quote that the duty to share information can be as important as the duty to protect patient confidentiality. And all of the public engagement work I've ever seen demonstrate the real enthusiasm of people and of in their role as patients and otherwise to share their data where it is clear that the benefits and the costs are distributed in a way that match their values. And I think again, organisations like the HDR UK Alliance can be key in promoting those values and therefore embedding in the system a really high quality and trusted environment where people can donate their data to the public good, which I think all the evidence suggests people are really keen to do. And here again, I think the pandemic has provided all kinds of rather interesting opportunities. To start with, it has really driven high up the public agenda the whole notion of high quality data in this space. You get, people standing up in a whole variety of high profile positions demanding to see the data, which is something one would never have expected, however long ago. We have had a very clear indication that the data and its interpretation are key. We have seen the process of science live on television as we've gone from we don't have the data, so we don't know. We have some data, so we're guessing this. We have more data, so we can more confidently predict that. That evolutionary process and how data feed into the iterative cycle of research and is just wonderful to see in the public domain. And the challenge and the alternative interpretations writ equally large. And I think that new understanding of the importance of data and its power, but also its limitations, is something to take away as a message as we move forward in that deep public engagement that Caroline highlighted as crucial in this space, and to develop and to build on from the way in which really impressive use of data has been so evident in the pandemic, to use that as a platform to build this really high quality research data alliance as you are, with deep public engagement, so that we can achieve that ultimate goal of connecting discovery to public good, which everybody can completely get behind. So I'm really delighted to be able to contribute to this extraordinary effort, and I wish you a very successful day discussing these really key issues. Thank you very much.
Thank you, Ottiline. Really, really interesting, and you covered so many topics and things in there. May I just ask one very quick question and things, which is around, so you kind of the theme today is around all of us together. The kind of the skills and the capabilities needed to do that kind of that kind of transformation, the evolution and transformation you kind of described there. What are your thoughts in terms of how we should be thinking about that?
Absolutely. So it's one of the things that I like to emphasize when people talk about infrastructure. I think there are two sorts of infrastructure. We tend to think of it as the hard stuff, I mean, the physical stuff, although actually, you know, when you're talking about data, yeah, even that's a little bit questionable. But I'm very keen on this concept of social infrastructure, which a colleague of mine, Andrew Millar, introduced me to the term. And it kind of refers to the structures and organizations and systems that you need to ensure that the right people are brought together in the right combinations in the right way. And that includes that the right people come into the system in the first place. So all of those engagement and training activities, all of those interesting career paths that we need to weave together. And I think, as you highlighted in your introduction, in the context of data, this is particularly interesting and exciting because that your work is so much at a hub in the way the whole system works, that not only do you need that right diversity of skills and people sitting in that hub doing the dealing with the data, you also need those incredible interfaces right across with all your key stakeholders from, you know, all across the healthcare and the policy system and out into the patient groups and more wider society. So I think your work is kind of emblematic of the need, yes, for physical infrastructure, but crucially for this deeply interconnected social infrastructure that builds those alliances that you need to make it work.
Wonderful. Thank you so much, Ottiline. I really appreciate your time this morning on that. And thank you for opening us so beautifully. So I'm going to go into the next session now, which is on to the Black Internship Programme. So I'm absolutely delighted with myself and my colleague, Martin Levermore, are going to introduce this. So the next slide, please. So to enable discoveries that benefit all of us, and I think drawing out many of the points that Ottiline's just made in her opening kind of presentation there, we need to have health data science needs to include that diversity of data, but also diversity of people, the diversity of skills, and diversity of perspectives. So we really do deliver benefits that represent and benefit all of us. And today we're really pleased to be launching the Black Internship Programme for Health Data Scientists. And this is in partnership with the 10,000 Black Interns Programme, which was recently launched. And we're really pleased that, that health data science is one of the leading sectors in this initiative. And what we're able to do in health data science is bring together, and as Ottiline kind of mentioned, that kind of the set of skills across the Alliance and the different organizations drawing together. So through doing this, and I think that the Black Internship Programme is a fantastic example of we're able to offer to this new group of people coming to health data science a breadth of different organizations to get involved in, a different set of areas to get to learn about, and have just a wonderful experience of health data science. And these organizations have already volunteered to be involved in the internship programme. And why this matters is it's starting to address the underrepresentation we know that we have of Black health data scientists. And it's also, I think, through COVID, but also through all sorts of diseases and conditions, the effects on different ethnic groups. And we want to be able to therefore make sure we're getting opportunities for these groups, everybody to be involved in this work. And also to be able to grow the diversity of experiences, perspectives, and talents in our sectors. So we really are drawing on the greatest talent pool to be able to solve what are incredibly important national and international problems. And so we're opening the Black Internship Programme today, and the programme is going to be running next summer. It's going to be for 6 weeks during summer 2021. And we're going to be offering over 50 placements across 28 organizations, and some, as you can see from the numbers there, are offering many, which is fantastic. All the internships are paid, and they're going to be giving these individuals an experience of a once-in-a-lifetime experience of learning about health data science and the development opportunities. And we really can do this by everybody working together. And again, this is just a great aspect of today's theme. So by supporting this vital programme, we would just really encourage you to be able to share the links, be live on our website from 9 o'clock this morning, and you can then and encourage you to post as well, so that we draw on the greatest number of people to get involved in the programme. And it's on that note that I'm absolutely delighted to welcome Professor Martin Levermore, who's the founder and chief executive of Medical Devices Technologies International, and the chair of the External Advisory Board of Pioneer, the health data research hub for acute care. So Martin, it'd be great if you can share your perspectives on why this programme initiative is so important. So over to you, Martin.
Good morning, Caroline. Good morning, all. The theme for today is all of us together, but I would like to change it slightly and say we're all in it together. And as Ottling wonderfully pointed out, collaboration and social collaboration is part of the glue that is actually going to get society down the road, and more importantly, ensure inclusivity and diversity takes place. Just a little bit back about myself. The term about 18 months was coined, the Windrush generation. I never thought I was a part of the Windrush, but my parents came as part of the Windrush and decided to have the 5 of us, my other brothers and sisters in the UK. But over that period felt there was some sort of inequality, and that was the inequality of education. And as such, I was, with my siblings, taken back to Jamaica in order to be able to see the opportunities that people like myself, those of a broader community, can actually engage across all forms of society. The interesting part of that lesson learned, back to the UK in the 70s, and the latter part of the 70s, to understand how best we can start breaking down social barriers. And obviously education, careers are an important facet. Social mobility for all cultures, for all creeds, is an important tool to leverage up. And no better career opportunity these days than in this, what I would like to term, sexy career of healthcare data science. Many of young people have asked me over the period of years, what is this? What is health data science? What is it all about? We might call it part of the life science sector, but actually, most importantly, it's about sharing of information, sharing of knowledge, and really trying to undertake solving real life problems. So this is an important occasion, and the work that HDR UK is doing and the Alliance is important also to widen the breadth of the talent pool. That talent pool does exist, and the more we can actually tap into that, the better we can actually find, resource, and deal with real human life problems. I'll go back as a son of a Windrush generation, whose father was a bus driver, whose mother was in the NHS. We should not see the Windrush as a negative or scandalous situation. It is about success, a living inbred success. And the program that HDR UK is now launching goes to show that level of engagement to reinforce and rebuild the next generation of future leaders. So I'm actually extremely delighted, Caroline and co, that the vision of what will take place, not what is it or is it not, it will take place, where healthcare data scientists will lead in transforming society is an important part of the total inclusion and diversity. So I'm overly excited about this opportunity. I know from the UK, as we move out of Europe and embrace the rest of the global world, we can't forget our Commonwealth brothers and sisters, who again form part of this wonderful climate of diversity. Thank you, Caroline.
Thank you, Martin. That was beautifully put. And I'm so excited about the people we're going to meet over the coming months as they apply for the programme and get involved next summer. I think, as you say, it's just a fantastic way of starting to grow the next, our future generation of leaders in health data science. And thank you so much, Martin, for your involvement in that. So on that, I'm now going to take us into the next stage of of today. So I'm going to give a short presentation on the story of health data research in the UK since the last symposium. And so health data research uses data about all of us to enable discoveries that improve all of our lives. And HDR UK's mission is this, and our vision is that by doing this, we'll see large-scale data, advanced analytics that really benefit different patient interactions, clinical trials, biomedical discoveries, and enhance public health. And you can already see how this is happening in so many different ways. And I think, as Ottoline mentioned this morning, the kind of Google DeepMind is a great reminder of exactly what this can look like. Next slide, please. So that sounds all very obvious and in some ways could be quite simple, but actually achieving this is going to require all of us, a lot of things coming together. So it requires a real diversity of people, of skills, of sources and uses of data, so that we really are drawing different aspects together on that. And at HDR UK, we see our role in actually helping to unlock this potential, because there's a huge amount of complexity with it, but the potential is absolutely enormous. And we can only do this by working together and working with everyone to be able to make this happen. And so through this presentation, I'm going to give an overview of where we are in the UK and then explore with my panel colleagues what we've collectively learned and what the implications are from this. So we'll start with COVID. I'll start the presentation with COVID and we'll come back to COVID at the end. So health data research really has kind of underpinned many of the discoveries that have helped the UK and other countries during the pandemic and continues to do so. So using data, we've learned much more about how the disease is transmitted, who's affected by it, and who's most vulnerable. And we've also learned what works to treat it. And I think, as Ottoline mentioned, that evolution over time has been kind of seeing the learning happening has been extraordinary to see. Next slide, please. But these discoveries are not made by one researcher alone or one type of researcher. They bring together a really kind of great mix of different skills and capabilities. So you've got examples of researchers working on understanding causes of disease, where they're doing genetic sequencing of COVID-19 to see where the strains have come from and where different outbreaks have happened. You've then got the clinicians working in better care, understanding the impact of COVID-19 on particular vulnerable groups, say within the acute sector or in social care settings, around cancer or heart disease or other areas. And then you've got the trialists who are working on understanding which drugs work, which vaccines work, and which don't work. So, and you've seen with dexamethasone, the example from coming through from the recovery trial, that really it has shown that this relatively straightforward way of actually making a real difference to people in hospitals. And then obviously in public health, I mean, that's been around us, all of us, seeing the impact and the benefit of using data to inform public health policy. And Wales has been a good example of that. So as shown, we need a really, as this conversation so far has shown, we need a real diversity of people with different skills need to do health data science. And therefore, we're investing in people, developing these people to build skills, with over 1,500 people already receiving training to date. And we want to grow health data science and scientists across industry, academia, NHS, government, and charities, all working together to make discoveries that using data that benefit all of us. But these people need to have access to data to be able to do the health data science. The Gateway was launched earlier this year, and it provides a single front door to enable you to discover already over 530 data sets for research and innovation, and so much more. I encourage you, the link on the website's here, to go into it, and you'll see there are data sets, but also tools, there are papers, there are projects, there's also training courses to help you understand the data better. And every day things are being added. So this slide gets updated on a daily basis because there's so much coming onto it now, and it really does feel like it's a snowball happening of more and more coming on board, which is fantastic. And this is only possible through the Alliance. So this slide, which looks incredibly busy, but I think tells the story very well of the number of organizations that are coming together to work together to make data discoverable and safely accessible for research and innovation. So you'll see on this slide organizations from across different hospitals. We can see different hubs. You can see charities of different disease types in there. You can see national data custodians in there. So all of them working together, which is absolutely phenomenal. And I'm absolutely delighted to welcome the newest members, which are Public Health Scotland, which is a national agency for improving and protecting the health and well-being of the people of Scotland, and the UK Brain Bank, which was set up by the Medical Research Council in order to provide a coordinated network of UK brain tissue resources for research. So a very warm welcome to those organisations. And we're already seeing people discovering UK health data from across the world. So we've got over 8,000 people globally using going through the gateway, and we can see nearly 8,000 searches per month on that. We can also see from the access requests that people are using it to access data, and we already estimate it's a route for, it's getting towards 10% of the UK data access in the UK coming through that, despite just being a few months old. And we keep the stats on the front page of the gateway, so you can see the whole time what's happening, and so we can learn together. And today I'm really pleased to let you know that the Gateway is now enabling more streamlined access to many of these data sets and using the 5 Safes framework. This has involved a huge amount of effort from data custodians to build alignment across access approaches. Data sets from the 8 custodians listed below from today can now be safely accessed through this new access management process. And this is a major step forward in one of our first commitments, which is to make improve trustworthy access to data. And by working together with researchers, custodians, patients, and the public, we're going to continue to make this better and better. But researchers also need, as well as being able to access the data, they need to get to the right quality. And Ottoline also mentioned this in her opening speech. There's been a huge amount of work that's happening on this across the community. The new data utility framework allows researchers to understand what quality data is currently, what quality data currently is, and also to see the effectiveness of different improvement approaches. And you'll be hearing more about that later today. In addition, work done by teams on phenotypes, previous slide, please, and applied analytics are crucial to make data useful to researchers. And this work has created a thriving community of people who are creating the underpinning tools and standards and methodologies needed for all of us to use the data. Next slide, thank you. So as well as having the access, so the discovery, the access and the quality, we also need to have access to expertise, knowledge and ways of working to maximize the insights from the data. So health data research hubs, which include hubs with expertise in clinical trials and real world evidence, and also disease-specific hubs, including respiratory, cancer, and also the BHF Data Science Centre, have collectively supported over 235 contracts, supporting research across industry, academia, and the NHS, and that's just in their first year of getting started. They play key roles in uniting, improving, and using data to support the UK's COVID response. So I started this talk talking about COVID, and I'm now coming back to it. I think COVID has shown the value of people working together in partnership across sectors to solve urgent problems. And the National Core Studies programme led by Patrick Vallance is a really fantastic exemplar of this. It's brought together leaders from across the Office of National Statistics, the Health and Safety Executive, and a breadth of leaders from academic disciplines. And building on lessons from the first wave to answer these really key problems and challenges as we look ahead in COVID. And all underpinned by this National Data and Connectivity Study, which HDR UK is leading in partnership with the Office of National Statistics to ensure these different problems are getting the data that they need to be able to answer them rapidly during the pandemic. Next slide, please. So this rather busy slide talks through the, kind of gives you a sense of how the data is growing. You can see the vertical side, you can see the different national data custodians, and on the horizontal, you can see the different data sets that are being steadily added on. And this has been kind of developing over the previous months. The more green this page is, the more the data is accessible and discoverable for people. And so you can really see the amount, how that's growing, and working through sprints on a monthly basis, adding more and more on, so that we really can make this extraordinary asset, which means you can go from being able to do research on small numbers to actually just really quite very significant numbers, which is what we can achieve through working together across the 4 nations. So this is an incredibly exciting and important programme. Next slide, please. And as a result of this partnership, we're seeing large-scale collaboration and coordination across hundreds and thousands of people. And we're seeing research being generated at an extraordinary pace and scale on COVID using health data. And you can see on this slide, there's already over 1,000 COVID preprint publications that have been using health data, which is an extraordinary achievement. Next slide, please. And this work all relies on involving and engaging patients in health data research in new ways. So you'll see the numbers on here are quite humbling of the number of people who've got involved and wanting to help shape and bring their perspectives to ensure that we really are doing the best health data research that benefits everyone in there. And I think this has been a really important part of the whole COVID aspect in there. Next slide, please. So there's so many examples that we could use during COVID, but I wanted to kind of share one from the Principle trial. So for those who aren't familiar with Principle was established to find treatments for COVID-19 in patients, for older patients who are in the community setting. However, as you can imagine, it's challenging to find and recruit people in the community where they're kind of spread out all across the country. But by bringing together a multidisciplinary team, which included governance and technical experts from NHS DigiTrials, patient engagement experts, the Information Commissioner's Office, we're able to kind of create an approach which identifies eligible participants for trials within 24 hours of receiving a positive test in the community. This really is quite extraordinary being able to do that. And has involved 92 members of the public to test the approach and to ensure kind of it really is done in a way that people can trust. And there are 4 key benefits I think came out of this approach. First of all, we're getting twice as many participants into the trial. Secondly, reducing the time between when someone's tested positive and being recruited to the trial, which is absolutely crucial. More treatments then being evaluated through the increased number of recruits, and increased safety for participants by using summary care record data. And this additional recruitment has already enabled the trial to add a new arm, which is absolutely essential we need to be understanding and evaluating different possible treatments. Next slide, please. So the focus I spoke about so far has been very much UK focused, but clearly COVID and health data research has a very important, and we'll be exploring through today, the impact and scaling up on an international stage. So ICODA, which is the International COVID Data Alliance, which is about advancing open science globally and really thinking about how we reduce the harms of COVID-19 for all of us. The focus on this has been around lower and middle income countries, which is a really important theme of benefiting everyone and the fairness and equity across all of this. Next slide, please. And this is brought together, as much the theme today, this alliance of bringing people together to work together. So you can see from here the diversity of organizations who are working in partnership on this across international boundaries and different sectors and expertise, and also the collaboration of funders around this, which is extremely exciting to see on there. So it's wonderful to be talking about how much has been achieved, but the really key message I want you to take away from today is just think how much more we can achieve together. A very wise colleague reminded me of this saying recently, and it underpins today. If you want to go fast, go alone, but if you want to go far, go together. And this leads me into our panel discussion. I'm delighted to have 4 exceptional leaders join us today, representing different aspects of health data research. So first I'd like to introduce, so Derek Stewart is a patient representative from HDR UK. Then Jill Hopkins from Roche and Genentech. John Dinesh is a research director at Health Data Research UK, but many other roles. And Ami Banerjee, associate professor in clinical data science and honorary consultant cardiologist at University College London Hospitals, UCLH. So a very warm welcome to all of you. And I'd love to start our discussion today by each of you telling us a little bit about yourself and what you're working on at the moment. So Derek, I was wondering if you could open up for us.
Hello, well, I'm celebrating 25 years since my throat cancer. So when you talk about how far we've travelled, it's amazing to see how welcome we are made to feel in the world of data research. And I think for a long time, that was stuff that happened in a cupboard. So it's brilliant to see that. And it's great to see the work of HDR UK with our public advisory board and the national network. So there are plenty of opportunities to get involved. So last thing for me would just say I've been working with PA Consulting on the development of the Innovations Gateway. And it's not just about having an input, it's what we get to learn about the work you're doing, how you go about it, and what it's actually finding out to benefit people's health and well-being.
Thank you, Derek, and many congratulations on 25 years on that. That's wonderful news.
Very good.
Thank you. Jill.
Hi, good morning, good afternoon. I'm Jill Hopkins. I'm a retinal specialist by training and ophthalmologist originally from Canada. Proud to say I did my fellowship training at Moorfields Eye Hospital in London. So always wonderful to be associated with the UK. I spent 20 years in clinical and academic practice in various countries of the world and have been 10 years in industry working in retinal disease research. My current role is head of the global personalized healthcare program in ophthalmology. And personalized healthcare for us means really looking at how do we harness the power of data, digital and analytics to really try and tailor treatment plans for patients living with retinal diseases. So in this role have been actually as well the industry lead on the Insight program, the Health Data Research Hub associated with HDR UK. So delighted to be here in that capacity today as well.
Thank you, Jill. And as you're joining us from the west coast of the States today, thank you so much for getting up so or staying up so late. So much appreciated.
Pleasure.
John.
Thanks, Caroline. So I'm John Dinesh. I'm, as Caroline said, Research Director of Health Data Research Cambridge, which has a national role in coordinating activities that link molecular science with health records to enhance understanding of causes of disease and the subtypes of disease, with a view towards helping come up, laying the foundations for new therapies and drugs for conditions, and particularly tackling difficult questions like the shared underpinnings of multiple different conditions, which may be important to problems such as multimorbidity. As part of the general pivot, as we all have towards COVID-19, I help support a number of initiatives that, again, follow the theme of trying to track various molecular signatures of the virus or host characteristics with health records to try to help understand and control the new coronavirus.
Fantastic, incredibly important work. Thank you, John. And Amy.
Good morning, Caroline, everybody. I'm Associate Professor in Clinical Data Science and a cardiologist at University College London. And I'm very much resonating with what Derek said throughout the pandemic. The work that I've been involved in has been listening to the patients. I think William Osler, to paraphrase him, once said that listen to the patient, he's trying to tell you what's wrong. At the beginning of the pandemic, we were working on high-risk conditions such as heart diseases and lung diseases, because that's where the big effect on intensive care admissions and deaths was happening. And then my patients and other in cardiology and people in other specialties were facing indirect effects where their services were being slowed or stopped and facing the effect of that. And now we're hearing about the longer term effects of long COVID. And that I think tells the story of how data is the enabler to help us answer the questions that people and patients want us to answer.
Thank you, Amy. And that takes me on to the kind of first question I was going to put to you in the panel, which was, I mean, it clearly has been an extraordinary year. I'd just be really interested to hear from your perspective, what is the biggest lesson you feel we've learned from data over this period? And Ami, I was wondering if you could perhaps open on that.
I think that we have both the breadth of data because of NHS and because of the networks and the infrastructure that bodies like Health Data Research have, but connecting it with the questions from the health and social care system and patients and public. I think that's a lesson I personally have learned, the power of that engagement and connection is the biggest lesson I personally have learned.
Thanks, Ami. Others, anyone else thoughts on lessons from through COVID on data?
Yeah, I think I would just add, I mean, it really has shown us the power of having data organized in this way, right? When you set up these capabilities to be able to access data, learn from it in real time for crises, it's a huge benefit. And we've really thought about it from, an ophthalmology standpoint. What we found, I mean, obviously COVID has been the major driver of what healthcare has been focused on. But when you look at, for example, in the UK, there were some, 10,000 appointments for retinal care canceled due to the pandemic, 8,000 injections that were missed. And these are for treatments that would maintain people's vision normally. So how do you then start to build upon that to say, okay, how do we triage once things open up to get people most in need back into the clinics at the right time? So for me, it's that capability of when the data is set to answer key questions, you can access that and answer the questions that are of the prime clinical importance for patients and caregivers in times of crisis and beyond, as we try and restore healthcare services again.
Very interesting, thanks. Derek.
I think the biggest thing was when we saw the number of people from Black and South Asian communities that were affected by COVID. And it made us realize how we're not capturing that data in so much research we do. And I think if there is one thing that comes out of this, is that we'll now capture that data, because clearly, and it's just a matter of health inequalities. It is bringing those to the fore and maybe gives us the opportunity to address those in future.
Thanks, Derek. And John?
I think a key lesson has been, at least for the type of work that I've been involved with, which starts with molecules, is that the laboratory information is really quite limited when it's not connected to the real world of human health experience. And that bridge to the real world, between the laboratory and the real world, is electronic health records. Metadata, detailed health records. And once that link is broken between the lab and the real world of health records, the value of the molecular data, whether it's about the viral genetic code, the human genetic code, human levels of antibodies against the virus, the value of that information suddenly becomes very, very much diminished. Whereas if there are dynamic linkages and diverse linkages that can be achieved, suddenly the value of the information is enriched. I think that's been a powerful lesson and has lots of implications for configuring our health data science landscape for the future.
That's a really interesting point, John, which kind of takes me on to my next question. If you were to looking ahead then, what could we achieve from this? So what do you think health data research could look like if we kind of look 5 years ahead from here?
Well, I think that's relates to what are our goals, right? So I think some of the lessons that have emerged in the last 7-8 months are that a sense of pragmatism and urgency can help us collectively make huge progress. I think a lesson is that our systems are very complex. Our health data economy is difficult to navigate, that we need to have a careful review of how things work, to think about how to improve. But I think the key questions are, what is it that we need for the next wave of health crises, whether they're infectious disease, such as pandemics, or non-communicable disease crises, or this hybrid blend that we're likely to have. And it seems to me the key things that we need are to configure our system so that we're able to make dynamic connections where the databases are increasing, both in terms of the individuals who are involved, the information that's being generated in the lab on these individuals, but also dynamic in terms of the connections with various databases. And at the moment, we're not really well configured for dynamic connections. Second is to be really well configured for diversity. The diversity, of course, relates not only to areas, very important ones that Derek mentions, in terms that, for example, our systems aren't very well configured to capture and record information on ethnic diversity. I think we need to improve that, but also in terms of the diversity of the record systems. So many of the relevant record systems come from government and public health agencies, but actually quite a lot of them come from professional organizations, such as the Critical Care Database, which has proved to be really important to the so-called ICNARC database, to everything. And yet it relies on a small group of people acting heroically and probably rather insecure funding. It also relies to some extent on private companies. So we've seen the power of being able to ally with private vendors, the system suppliers to general practice records, and how they have a part to play. So that diversity of the landscape means that we need to configure ourselves to be able to be both dynamic in the linkages, but also connect diversely. And then there's also the issue of multiplicity, because everything is repeated at least 4 times with the political and economic landscape of the UK. That diversity is a challenge as well. So for example, before the COG UK Viral Genome Tracking Project, there was really no effort that was bringing together unconsented data across the 4 countries, the 4 devolved countries in terms of health data. And that's been a challenge as well, where essentially one has to come up with a 4-fold replication to federate the analyses. So I think I think the crisis has highlighted opportunities, particularly where pragmatism and urgency prevail, but it's also highlighted how we probably need something of a renovation of our health data landscape after the dust settles a bit.
Brilliant. Thanks, John. And Jill, so from your perspective, what would I don't know, are there aspects that are different from kind of looking at it from the kind of industry perspective to those that John's laid out there, or are there kind of commonalities?
I think there are a lot of commonalities. I think it was very well said, John. I mean, I think that the key thing we think about, we sort of talk about this meaningful data at scale, right? So that highlights a lot of the points you made, John, the sort of, it's large scale, it has to be high quality, it has to be diverse and generalizable, and then really that connectivity, right? So that you can link the right pieces of data, and that you're then able to ask key questions that are of prime importance. And Derek, I know you think about this a lot in terms of the patient voice here, but really, how do we build systems that are going to be taking into account, what is the data being used for, who has a voice in how those questions are being answered, and how do we really maximize the value of that routinely collected data? And I think that's something that the hubs, for example, are so focused on, is that as that data is coming in, can we look to a future where we're prospectively collecting data in a fair way, meaning the findable, accessible, interoperable, and reusable, but also in a way that's fully designed to answer the right kinds of questions. And one of the things I'm really proud of and excited about that we're working on in the Insight Hub is actually building something we call the Data Tab, a Data Trust Advisory Board, which is a cross-functional group of people, including patients, public, academics who look at each proposal and weigh it for impact and value, either to patient or healthcare systems. So building in those systems or processes that make that quite seamless, I think is key to the future. And I hear you, John, it's complex. It takes a lot of time and commitment and financial commitment, but hopefully we get there, together as is the spirit of the day. But I think really building the systems that will support those kind of inquiries will be key.
Fantastic. And I'm seeing some really good questions coming in from the audience. So I'm going to cover, I've got a couple more I'm going to ask afterwards, but just wanted to jump into some of those. So I'll start first one, which was from, I think from Luke Redmond, which was around, perhaps, so he's asking, could we explore what the panelists think it would take to rapidly improve the quality of data collected at the point of care? There may be difficulties, and yet this could rapidly change the data research landscape. Ami, I was wondering whether you might be able to, if you've got some thoughts on that, being very much involved at the point of care.
Yeah, I think in health data science, we've made a mistake that we talk about being data centered, and actually we're people centered. That data comes from people entering it about people. And so when we forget that, the system breaks down. So at the moment, our electronic health record systems aren't always centered on that interaction and are centered on ease of data linkage and other aspects, or procurement and other issues, rather than that. And if we start there, the huge advances that we've seen during the pandemic, for example, on ethnicity, some of the data that we've been able to access from Office of National Statistics about household composition and occupation, which we hadn't seen in that kind of granularity before, is there, but it's because people asked the questions, including people in this network of Health Data Research UK. So I do believe the data is there if we look at it through the right lens.
Thanks, Amy. Anyone else on how we can actually, what we can do at that point of care to enhance data rapidly?
Well, if I could come in, Caroline. So one challenge at the start, particularly in April, was that perhaps in the urgency of acting, not joining up through co-design, which I think is very important in collecting the kind of information that Luke is suggesting, joining things up at the time when individuals are meeting healthcare or public health surveillance. So for example, when these car park testing facilities, so-called lighthouse labs, suddenly sprang up, and there's a lot of private sector input to try to get them up quickly. There wasn't, at that very early stage, the co-design to think through collecting information on individuals that would enable a solid link with their personal identifiers, so that the samples that were collected for back of the throat tests, these PCR tests, could then be irrevocably linked with health records going forward. And there was quite a loss of information at those early stages. So I think one of the lessons for that, and there have been various efforts to try to retrieve that information, some of which have been heroic and very time consuming, and much of it has been retrieved. But there was a threat that a lot of that could have been irretrievably lost because information wasn't being collected in the right way at the time when people were involved in their first interactions with healthcare. So I think that's been a key lesson about, through co-design and discussion, making sure that we have a much more rounded reaction to these crises and emergencies.
Caroline,
Derek.
I think for me, point of care still sounds like that's your business, not my business. So I have my Fitbit, I have my phone. There are opportunities where my health could be improved by messages and using data I already collect, rather than waiting for me to come to the point of care, the hospital, the doctors. So it's how do we also shift data a bit to make it about health and well-being, not always about ill health.
Really, really good point. Thank you, Derek, on there. So I'm just going to shift us to the question now Georgina's Humphreys has brought in. So around, do you think the academic sector will share data through HDR UK with the same enthusiasm as public health organisations? And what ideas do the panel have for improving the credit and incentive structures to share and reuse? Really interesting question.
Yeah, I think the early indications are very positive. I think the academic sector is leading the way. I think there is a spirit of sharing, a spirit of generosity. I think Health Data Research UK has helped catalyze and accelerate the already pre-existing enthusiasm in the academic sector for sharing information, sharing results, for open access. So I'm very positive about the academic sector's general reaction.
Anyone else got kind of experience or thoughts on that? Amy, did you?
I think I would agree with John that my experience has been very positive, whether wearing my clinical hat or my researcher hat, that people have realised that working together we're going to achieve much more, and that's what's needed now. I think that some of our structures in academia, such as authorship and how grants are awarded, maybe needs to be more distributive to recognize what are collective inputs and outputs, for example, across the whole network of Health Data Research UK, and many of the efforts you had on your slides, Caroline. And I think actually within Health Data Research UK, some of the work here is showing the sector how that can be done.
Great, thanks, Amy. I'm going to go to Jennifer's brought up an interesting question in terms of which Derek was getting to in his answer just now, which is around the how the qualitative data fits in with the massive quantitative data. So lived experience is often missed from the research picture, which is a really important kind of more holistic look at us rather than just narrowly looking at how we're experiencing life. Derek, did you want to give some thoughts on that?
So I should probably say that the best evidence 25 years ago and still today is voice box removal. So my clinicians were active in research, so they knew how to read the data. They also knew about what was important about quality of life. Otherwise, I would be having my thumb here to speak through a stoma. So I think gathering and having that evidence is really, really important. And I think it's the qualitative stuff that can sometimes make the difference between one trial and another trial, where the data is saying exactly the same thing. And we have to get better at capturing it.
Thanks. And Amy, you kind of touched on this at the start when you in your kind of opening piece about kind of as a patient, the patient can tell you what their issues are and things, and asking that. But what are your thoughts on how we make that more kind of systemic?
I think some of it is happening, whether we like it or not, in social media, in the broadsheets, on the radio talk shows, and it's making sure that we as whether it's scientists, as Health Data Research UK, as clinicians, are part of that conversation and are in listening mode, because there are questions where traditionally we've been hypothesis and researcher led in research, and there is definitely a place for that. But if we want to know about the need, we have to listen to the patients, the public, and the service, and policymakers as well at the moment sometimes. And I think we're in a unique place to have access to people and data to answer those questions.
Thanks, Amy. And Jill, from I guess it'd be interesting from the insight perspective, how you guys are thinking about that, and actually also more broadly at Roche.
Yeah, no, I think it's a great point, and Derek raises a good point that, you know, the capacity to do these digital data collections, not in the clinic, and much more linked to a patient's day-to-day quality of life, I think has tremendous potential. And we're really interested in that, both at Insight and at Roche, because you could say, I mean, you might look at, you know, standard traditional clinical trials that do a quality of life measure once every 3 months when the patient is in clinic. You may not find that correlates particularly well with where they are at their disease because it wasn't the right time to test it. If you could over 3 months have had 30 different quality of life assessments, much more relevant to their day-to-day functioning, be it from, you know, recovering from cancer or from a vision loss, that you really could start to see data that might be much more highly correlated and open up other questions we hadn't been able to answer before. So I think there's tremendous potential there. We think about it at Insight as well with, you know, the potential to check vision, for example, at home as opposed to coming into the clinic. And can you use that in a pandemic, again, to help triage patients? Can you also really just look at reducing the burden of clinic need if you can do that at home in a meaningful way, alerting when someone has to come into clinic. So I think that power of digital is massive. And again, it creates more data that then has to be handled appropriately and stored and voted into. But you're very interested in Insight of how do we start to bring in those other types of data into that hub and continue to maximize the impact we can have.
Yeah, really interesting as to where that could take us from doing that. I have got so many questions. There's so many more coming through, but I'm running out of time, which is unfortunate on that. So to close the discussion, I was wondering, Derek, whether you might be able to share what your expectations are from a patient perspective on what you'd like to see from the symposium today.
Just wish you all the very best. You're very brilliant. I just get shocked and surprised by every time I meet statisticians and data people. But the more detail you go into, the further away you take it from people and individuals. It's not just data, it's information about your loved ones, your families and friends. And it's as you get further and further into the detail, I just ask that you do a favor, that you look behind you and say, when did I last go and talk to patients? It's John's comment about the molecular scientists realizing they have to make that connection with people. So the more complex it gets, the greater the responsibility is to take patients and the public with you. And HDR UK have got that brilliant group, Public Advisory Board, Symposium and others working there. Don't forget to contact them because they're a willing resource. They'll challenge you, they'll make it difficult, they'll ask awkward questions, but that's our job. But good luck for the rest of the conference.
Thank you, Derek. I think that's a really important points there. And what a fantastic discussion. Thank you all so much for your time this morning. I really enjoyed it. I only wish I had more time. So what a good start to today. We're going to have a break now for 10 minutes. So please look at your brochures to select from the 3 really interesting panel discussions that come up after the break. And we're going to commence again at 10:45. This session is now going to end, and we look forward to seeing you again in the panel session at 10:45. Thank you all.